All right, so MSK upper extremity, this is a huge topic. There is so much in this. I really try to condense it down just basically to the highest yield things, the things that come up on exam the most. So I may not go over every single condition or every single detail, but I'm going to go over the things that come up the most on exams, the highest yield things. Thank you, as always, for the subscriptions, the nice comments. Everybody who signed up for the membership page, I truly do appreciate that. So thank you so much. Let's go ahead and get started with the upper extremities. Let's start with the shoulder, and then we'll work our way down. So anterior glenohumeral dislocation. This is by far the most common type of shoulder dislocation, about 95 to 97% of cases. Mechanism of injury. The most common mechanism of injury is going to be a blow to the abducted, externally rotated, and extended arm. So think blocking like a basketball shot. Less commonly would be a blow to the posterior humerus or a fallen and outstretched arm. But focus on the arm being abducted away from the body, extended, externally rotated, and then something hitting the arm in that position. On physical exam, what you're looking for is abduction, abduction, and externally rotated. So an anterior dislocated shoulder causes the arm to be slightly abducted and externally rotated. For diagnosis, you're going to get your x-rays, of course. That's going to include your AP view, your scapular Y view, and axillary view to visualize the dislocation. And then associated injuries. So there's a few associated injuries that may occur with an anterior shoulder dislocation. These are the Hill-Sachs lesions, Bankart lesions, axillary nerve injury. Wouldn't go crazy memorizing these specific injuries, what they involve, but just know they're associated with anterior dislocation. So really quickly, Hill-Sachs lesion is going to be a cortical depression in the humeral head made by the glenoid rim. Bankart lesions are going to occur when the glenoid labrum is disrupted during a dislocation and a bone fragment is avulsed. And then your axillary nerve. So there's a little bit more to know with this one. So this is really important for anybody with a dislocation of the shoulder to assess the neurovascular status. Axillary nerve dysfunction can occur up to 42% of patients with an anterior dislocation. So what you're looking for with an axillary nerve injury is what's called loss of sensation in the shoulder badge distribution. So basically, when you have an axillary nerve injury, you have dysfunction in this area. So you may have loss of sensation in the shoulder badge. So basically where a shoulder badge is, like on a cop uniform or military uniform, that's where you have the dysfunction in that area. So you can see what that looks like here. They also may have a loss of sensation or deltoid muscle weakness. And you just want to be familiar with axillary nerve dysfunction. That's very common in anterior dislocation, so look out for that as well. Treatment is pretty straightforward. There's not much to know here. You want to reduce in sling, so basically reduce the dislocation, immobilize it with the sling, assess for axillary nerve dysfunction both pre and post reduction. So there's a lot of random things to know with anterior glenohumeral dislocations. So I have a mnemonic for you. How do you remember all the little things you need to know? And that's the way you remember that is you remember a guy named Antonio. So Antonio is this guy. Antonio, you can see here, and Antonio helps you remember anterior shoulder dislocation. So what is Antonio doing? He's holding a picture and he's holding an axe in one hand. So the picture here has a bank on top of a hill. In his other hand, he's holding an axe. And both of his arms are up, they're abducted, and they're externally rotated. So what does this all mean? So Antonio, anterior shoulder dislocation, helps you remember in this picture here that he's holding a picture of a bank on a hill. That helps you remember your Bankart lesions, and it helps you remember your Hill-Sachs lesions. So that's your picture there. On the other hand, he's holding an axe. That helps you remember it's associated with axillary dysfunction. And then again, his arms are abducted, they're externally rotated. That helps you remember the presentation on physical exam, also the type of injury, the mechanism of injury that's most common. So again, you remember Antonio holding a picture of a bank on a hill, Bankart lesion, Hill-Sachs lesion. He's holding an axe in the other hand, axillary dysfunction. His name's Antonio. That helps you remember anterior dislocation. And then his arms are up and out, abducted and externally rotated. That helps you remember basically all the things you need to know for anterior dislocation. So remember Antonio. Okay, moving on to your posterior glenohumeral dislocation. So these are much less common compared to anterior. They only occur in around 2 to 4% of patients. Mechanism of injury is very important. Anterior dislocations wasn't so high yield. Posterior, it is. So remember, this is unique. And if you've listened to any of my other content, I always say if something's unique, they're going to ask you a question about it. So keep that in mind. So the mechanism for posterior dislocations is seizure, electric shock. Those are the ones you absolutely have to know. Of course, any trauma like a blow to the anterior portion of the shoulder can cause a posterior dislocation, but what you should focus on is violent muscle contractions following a seizure or electrocution, because those are the unique components that they're going to like to ask you questions about. Generally, it's going to be like about seizures a lot of times. So remember those: mechanism of injury, posterior dislocation, seizure, electric shock. Physical exam, this is going to be opposite of what we talked about in an anterior. So in this case, it's going to be adducted, I guess you would say, adducted, and internally rotated. So usually the patient will hold the arm in adduction and internal rotation and is unable to externally rotate. Again, remember this is different than anterior, which was abducted, abducted, and externally rotated. So again, remember posterior, adducted, and internally rotated. Now diagnosis, you're going to of course get your x-ray again, but what you're looking for is something called a light bulb sign. So be aware, light bulb sign of posterior dislocations, because they may ask about this. So on the AP view of the humeral head is going to be internally rotated. And because of this, the tuberosity of the humerus won't be visible. So they're not going to be projecting out laterally. And because of this, the humeral head takes on this circular appearance, which we can take a look at here. And supposedly this kind of looks like a light bulb. I guess it kind of does. You can see because it's internally rotated, the tuberosities aren't showing here. And it just looks like this circle, and then you have like the stem of the light bulb. That's called the light bulb sign. So be aware, they may mention that. And then treatment, very low yield, reduce and sling. So posterior dislocation, there's a few things. You want to remember your seizure and your shock can be the mechanism of action. You want to remember their arm is going to be adducted and internally rotated. And you want to remember the light bulb sign. So how do you remember that? You remember that by somebody holding a poster board that has a sign. If you add your finger into a broken light bulb, you'll get shocked. So they're holding a poster board, and poster board, because that helps you remember posterior dislocation. And it says if you add your finger into a broken light bulb, add adduction into internal rotation, because remember that's the physical exam findings you'll see in a posterior dislocation, into a broken light bulb. Light bulb, remember the light bulb sign on x-ray, you'll get shocked. Remember, most common mechanism of injury is going to be an electric shock and seizure. So remember again, if you add your finger into a broken light bulb, you'll get shocked. This is on a poster board. That's all you need to know for posterior dislocations. All right, moving on down to rotator cuff injuries. This is a pretty big one. There's a lot of high yield stuff here. Good amount to know. You'll probably get a question on this. So let's go over rotator cuff tears and impingement. So the different injuries with rotator cuffs. First thing that I wanted to go over is the mnemonic. You've probably heard about it. It's a famous mnemonic. It is not mine, but it is the SITS mnemonic, just to remember the muscles that are included. So supraspinatus, infraspinatus, teres minor, and subscapularis. That's just to help you remember the muscles in the rotator cuff. Now the mechanism of injury, few different things. So you may have degeneration, which is going to be a chronic degenerative tear, usually seen in older patients. You may have impingement, which chronic impingement can also lead to a tear. And then you may have an overload injury, like tension overload in athletes who are continually throwing a baseball, or jobs with repetitive overhead movement. In general, the cause of rotator tears is multifactorial. Degeneration, impingement, overload can all contribute. There's nothing really here I'd say that's super important to memorize. The high yield things for rotator cuff is more in the presentation and physical exam tests. So let's talk about those. Now, clinical manifestations. There's really two things you need to know. That's overhead pain and pain at night. That's the key. So pain exacerbated by overhead activities. In the vignette, they're going to describe this patient that maybe is reaching up for a shelf and experiencing pain. Maybe they're brushing their hair and having pain. Things like that, definitely look out for. The location of the pain is usually going to be over the lateral deltoid, so the anterior lateral portion of the shoulder. And then they also may describe pain at night, so complaining that the patient lies on their shoulder at night, they're experiencing pain, kind of keeping them from sleeping well at night. That's the classic presentation to look out for in vignettes, the pain over the lateral deltoid when they're reaching overhead, or complaining of pain at night. In real life, though, it's possible just to develop weakness or decreased range of motion. Some studies even suggest that a large portion of rotator cuff tears are actually asymptomatic. But for the exam, you're looking for pain with overhead activities, pain at night, done. That's your clinical manifestations you need to look out for. Now let's talk about probably the most important thing, the physical exam. So there's a lot of special maneuvers for the rotator cuff when you're looking for both impingement and tears. But there's three that I feel you should be familiar with that seem to be tested on the most frequently. That's the Hawkins test, the Neer test, and the empty can test. So let's start with the Hawkins and the Neer test. These are both good tests to test for impingement. So Hawkins test. So Hawkins or Hawkins-Kennedy impingement test, this is when, I'm going to show you what this looks like here. The patient's shoulder is stabilized position at 90 degrees of elevation, and the elbow is bent to 90 degrees. The examiner is going to place an internal rotation force on the patient's shoulder, and then any reproduction of pain that's elicited by the internal rotation will be a positive test for impingement. So how I used to remember this is when you were a kid, did you ever call someone like a chicken and you did a little arm flapping thing like wings? That's exactly what it looks like in this test. It made me think of the the Hawkins test, because you have your shoulders up, your elbows bent. So when I see a Hawkins test, it makes me think of a hawk flapping its wings, and it helped me remember that this is the one where you look like you're flapping your wings like a bird or a hawk, elbow bent, shoulder elevated, and the examiner pushing the arm in the internal rotation. It looks like a bird flapping its wings. So you can kind of remember that's what the Hawkins test looks like you're flapping your wings like a hawk, and that's how I remember that. So this ridiculousness here. So remember Hawkins test, think of like a hawk flapping its wings. That's what the test looks like, and it'll help you remember if you forget what that is. Okay, moving on to the near test. So in this test, the shoulder is forcibly flexed and internally rotated, and we can take a look what that looks like here. So flexed and internally rotated, one hand's placed on the shoulder scapula area to keep the shoulder from shrugging, and then, which this guy isn't doing, but that's what you should do. And then the other hand is going to passively lift the shoulder all the way up to the, basically to the side of the ear there. The arm's internally rotated with the thumb facing down. Any reproduction of pain is a positive test for impingement. You're going to see some variations of this test, sometimes with the arm in neutral position rather than internal. Most of the time, though, you're going to have that internal rotation, thumb facing down like that, bringing the arm all the way up to the ear. The way that I used to remember that is because near is by the ear, because in this test, your arm goes all the way up and the shoulder winds up right next to the ear. So when you see the near test, remember near is the one by the ear. And then finally, the empty can test, which has the name in it. This is also known as the Job's test. It's a good test to evaluate supraspinatus function. Sometimes it's actually considered the gold standard test due to how well it isolates the supraspinatus in the way the arm's positioned. So what you do is you, patient's going to place their arms straight out, about 90 degrees of abduction, 30 degrees of forward flexion, and then internally rotate the arm completely. So the thumb's going to be pointing all the way down, and then the patient is going to resist the clinician's attempt to depress the arm. So the patient's arm, again, straight forward out, elbow extended, thumbs down as if emptying a can. That's how we get the name. And then the examiner is going to apply pressure at the top of the arm, pushing it down. And when the patient attempts to resist, you're going to see if they have pain without weakness, that suggests tendinopathy. If they have pain with weakness, that's consistent with a tendon tear. So there's other tests, but those are the few in my experience that were most often tested on, so definitely be familiar with those three. Now treatment's pretty low yield, conservative versus surgical repairs, nothing specific to know here. It's going to depend on several factors: duration of symptoms, the type of tear, partial versus full thickness, patient's age, activity level. That's going to guide the treatment as to whether or not they need surgical repair or if they're better suited for, say, physical therapy. Now if we're talking about impingement, tendinitis of the rotator cuff rather than a tear, treatment's primarily going to be physical therapy, NSAIDs, etc. You'll find the treatment for most of MSK is pretty repetitive. It's not very high yield, and that's why I kind of run through it quickly. There's just not much to know from an exam standpoint. So if I'm breezing over it, skipping in some cases, you'll just know there's really nothing for you to memorize. If there's something high yield, I'll make sure to bring it to your attention. Let's move on to adhesive capsulitis, also known as frozen shoulder. So this is exactly what it sounds like: painful and stiff glenohumeral joint that has lost the distensibility and range of motion. So it's a frozen shoulder. It's hard to move. Passive and active range of motion is going to be substantially reduced. Now risk factors, you need to know these. Diabetes, this is a really big one. Remember, frozen shoulder is very common in diabetics, and yet it'll very, very likely be a diabetic patient. There was actually a study. They showed the incidence of frozen shoulder, I cannot say frozen for some reason, in patients with long-standing type 1 diabetes, showed a lifetime prevalence of 76%. So diabetic patients, remember that as a risk factor. The other risk factor to know is going to be thyroid disorder. So particularly hypothyroidism may increase the risk of frozen shoulder as much as 2.7 times. And then there's some other causes that you should not memorize, like dyslipidemia, prolonged immobilization, stroke, autoimmune disorder, autoimmune disease, secondary problems after a shoulder injury. Focus on your diabetics and then your thyroid disorders. And then females also, it's more common in women, particularly in the 5th and 6th decades of life. It's actually very rare to see this in patients under 40. So in the vignette, be looking for a female in their 50s or 60s with diabetes or thyroid disorder. Diagnosis, nothing that I would know for diagnosis. It's really just a clinical diagnosis made the basis of the medical history and the physical exam. Imaging has very little value except to rule out differential diagnoses like osteoarthritis. Treatment is also pretty low yield. In most cases, frozen shoulder is a self-limited condition. Physical therapy is going to be the most commonly employed treatment option. You can also use glucocorticoid injections, NSAIDs, other supportive measures, but nothing really to commit to memory here. Let's move on to our supracondylar humerus fractures. So supracondylar, the fractures of the distal humerus. Children 2 to 7 years is going to be your most common. So this is most frequently going to occur in children between 2 and 7 years of age. So be looking for a child in the vignette. Supracondylar fractures are actually the most common pediatric elbow fracture. As far as the mechanism of injury, this is the first time we're going to talk about this, but foosh, you're going to hear this a lot. Foosh with elbow hyperextended. So extension fractures, 95% of supracondylar fractures are going to be extension fractures. And this is typically going to be from what's called a foosh mechanism. So foosh stands for fall on outstretched hand. And then in this case with the elbow hyperextended. We talked about this before, but the reason why we generally see this in children most common is because children have increased flexibility in the joints. They have this ligamentous laxity. And when they fall with their arm extended out, they're more susceptible to hyperextending the arm when they fall. And that hyperextension is generally what leads to this type of fracture, to a supracondylar fracture. So remember, supracondylar foosh with hyperextension will be your mechanism of injury. Now, diagnosis, you're going to get your x-rays and know your fat pads. So the only thing I think you should be aware of, at least for imaging when it comes to supracondylar fractures for the exam, are fat pads. So in a non-displaced or minimally displaced fracture of this region, sometimes you can't see the fracture easily on x-ray, but you will see a fat pad. So this elbow effusion, which is going to be your anterior sail or your posterior fat pad signs, that's typically what you're going to see. So let's talk about fat pads for a second. So these are what fat pads look like. You can see your anterior and your posterior fat pad. You see where just the area gets a little bit dark here. That is going to be your fat pad. So probably if you aren't familiar with x-rays or new to medicine, probably not too familiar with fat pads. So usually fat pads are not going to be able to be seen on x-ray. And I'm going to talk about this more when we talk about radial head fractures next, but generally fat pads, particularly posterior fat pads, you can't see them in an x-ray unless you have an acute injury. And then blood starts to collect. You have this hemarthrosis that elevates the fat pad out of the coronoid and the olecranon or olecranon fossa, and it makes them visible on radiographs. Actually, in 90% of cases where imaging shows posterior fat pad displacement, a fracture is seen on the initial or follow-up radiograph. So with the elbow, be looking for your fat pads. There's also something called an anterior humeral line, and if there's displacement of this line, it can indicate a displaced fracture. I don't think they're going to ask you about that, so really just focus on your fat pads, really the posterior. I'm going to go a little bit about the anterior and some details about that next when we talk about radial head fractures. But just know, look for your fat pads on your supracondylar humeral fractures, particularly with the non-displaced ones. Now, complications. There's a lot of complications that can arise from a supracondylar fracture. Vascular insufficiency, nerve injury, compartment syndrome. You want to make sure you're doing a complete neurovascular eval in these patients. You want to check the sensory and motor function of the median, radial, ulnar nerves. You want to assess the radial and brachial pulses. But what you need to be looking out for an exam question when it comes to complications of supracondylar fractures is something called Volkmann ischemic contracture. So contractures. So this isn't common, but it's definitely tested on a lot. So when you have this type of fracture, you have a vascular injury, you have swelling, this can potentially lead to compartment syndrome. And if that compartment syndrome isn't treated in a timely manner, the associated ischemia and infarction can lead to Volkmann's ischemic contracture. And this causes this fixed flexion. Let's take a look at this here of the elbow, the wrist, the extension of the MCP joints. To put this simply, it's a claw-like deformity of the hands, fingers, and the wrist. So for the exam, if you see Volkmann contracture, right away be thinking of supracondylar fracture, because this can be seen in other injuries of the arm, but it's most commonly seen in supracondylar fractures. So if they ask you about it, it's going to be about a supracondylar fracture. So associate those two in your head. Volkmann, supracondylar, supracondylar, Volkmann, or you can just remember what I did and remember my Volkswagen is in super condition. So my Volkswagen is in super condition helps me remember anytime I see Volkmann contracture, I should be thinking that my Volkswagen is in super condition, because Volkswagen helped me remember Volkmann contracture, and super condition helped me remember supracondylar fracture. So remember that, because if you see it, it's going to be associated with a supracondylar fracture. Treatment, like most things in MSK, like I went over before, is pretty low yield, splint for surgical. So most non-displaced or minimally displaced fractures, you'll apply posterior splint and sling. Displaced fractures generally will be repaired surgically, closed versus open reduction with percutaneous pin placement. Nothing really to memorize there. So for supracondylar fractures, remember, it's very likely going to be a young child in the vignette. It's going to be a foosh injury with hyperextension. Look for your fat pads on x-ray. Then finally, remember your Volkmann contracture for potential complications. Remember, my Volkswagen is in super condition. Moving on to radial head fractures, really just a few things to know here. Mechanism of injury is going to be another foosh. So another foosher, just like in supracondylar humeral fractures. Many other fractures of the arm too. So fall onto an outstretched hand, it's going to be the most common mechanism with this type of injury. There's this sudden impaction of the radius onto the capitulum, and that's what's causing the fracture. Diagnosis, fat pads. So this is the star of these type of fractures. So let's talk about fat pads a little bit more. So the fat pads in radial head fractures are really important, even more so than supracondylar, because in non-displaced radial head fractures, these can very often be missed, and the only thing you're going to see is an elevated anterior and posterior fat pad. They can be the only signs of an occult radial head fracture. So be looking for fat pads in the vignette and in real life. A little bit of extra knowledge that I wanted to talk about with the fat pads. So anterior fat pads can actually be a normal variant, particularly in children. But posterior fat pads, they should really never be visible. They'll almost always indicate trauma. So again, remember, anterior fat pads can sometimes be normal, while posterior will almost always indicate a fusion caused by trauma. That may just be a little bit of extra knowledge for you and your preceptor maybe to talk about it and sound smart that you knew that. But remember, anterior sometimes can be normal, posterior or almost never, the way I used to remember that. Anterior fat pad can be a-okay, posterior fat pad is always problematic, so you remember that. Okay, treatment, again, not much to know here. Like most of these, splint versus surgical, depending on the severity of the fracture, mobilization with a sling or posterior sling splint may be sufficient. Surgical repair for your displaced or more severe fractures. Again, little to no for radial head fractures. Remember your Fuchs injury, your fat pads for those occult fractures. Occult fractures, if I didn't mention that before, what that means is just a hidden fracture. It's not visible in imaging. Let's move on to our ulnar shaft or our nightstick fractures. Very little to know with this one. I only bring it up because maybe it might come up on an exam question. The main takeaway here is to know the type of injury that is related to the specific fracture. So this is an isolated ulnar shaft fracture. The mechanism of injury is going to be a direct blow to the forearm. So basically this, if that happens. So these type of fractures are almost always a result from a direct blow to the forearm. This happens when the patient is using the forearm to protect their head or torso from a blow. So if you're familiar with the mechanism of injury, if you see it in a vignette, you may be, get the question right, know you're looking for an ulnar fracture in the answer. So nightstick, somebody hitting like a stick to the forearm there, can result in this nightstick fracture, isolated ulnar shaft fracture. Treatment is going to be non-operative treatment versus surgical repair. So casting splinting is the accepted approach for uncomplicated nightstick fractures. If the fracture is comminuted, over 50% displacement, these type of fractures are better suited for surgical repair. Let's move on to our Monteggia and our Galeazzi fractures, which I probably say wrong, but I don't know. So with Monteggia and Galiazi fractures, the only thing I feel like you really need to know, the thing that's always tested on, is what bone is fractured and dislocated in each. The rest of the stuff's pretty low yield. So what you need to know is that a Monteggia fracture is a proximal ulnar fracture accompanied by a radial head dislocation. And that's what that looks like here. So you can see the fracture of the proximal third of the ulna, very significant fracture here. And then the radial head popped right off there, the anterior dislocation of the radial head. So that's Monteggia, proximal ulnar fracture, radial head dislocation. And then Galeazzi is going to be a radial midshaft fracture associated with dislocation of the distal radial ulnar joint. So we can see what that looks like here. So you can see the fracture of the mid shaft of the radius, and then you can see down here the distal radial ulnar joint, the ulna popped right off. So that's what a Galeazzi fracture looks like. Now, diagnosis is going to be just with x-rays, which is pretty straightforward. Your treatment is going to be surgical repair because generally in both a Monteggia and a Galeazzi fracture, they're very unstable fractures. They almost always require surgical treatment, particularly with Monteggia fractures. So most of the time this is going to be with an ORIF, open reduction and internal fixation. So again, remember the highest yield thing is remembering which fracture and dislocation is of what bone in each condition. So the way that you remember that is by remembering gruesome murder. So gruesome murder is you're going to look at the first three letters of each, and that's going to tell you what's fractured first and then what's dislocated second. So gruesome stands for, the G stands for Galeazzi, the R stands for radial fracture, and the U stands for ulnar dislocation. Now, yes, I know I said distal radial ulnar joint is what's dislocated in a Galeazzi, but most of the time this is what you're going to see. The ulna is going to pop off of that joint, and this is going to be the main thing you'll see on x-ray dislocated. So just remember that as an ulnar dislocation. And then murder is going to stand for Monteggia. The U, the first one, is going to be your fracture. That's going to be the ulnar, that's the ulnar that's fractured. And then the R stands for radial head dislocation. So again, remember when you have a Monteggia or a Galeazzi, and you can't remember which is which, just remember gruesome murder. GRU, Galeazzi, radial fracture, ulnar dislocation, aka distal radial ulnar joint, and then murder stands for Monteggia, ulnar fracture, radial head dislocation, and you'll never forget which is which. That's the highest yield thing to know. All right, let's talk about radial head subluxation, aka a nursemaid elbow. This is important to know because it may come up on an exam, but the thing is, if you work anywhere with pediatric patients, you're going to see this all the time. I used to work in urgent care years ago. We always saw this. So what this is a movement of the head of the radius under the annular ligament. So let's take a look at this here. But we talked about this a little bit before. The ligaments in children, they're much more lax and weak. So in a child, when they have this sudden pulling on the arm, as you can see here, you pull on their arm for whatever reason, the parents are pulling them up, they're playing with their brother or sister, and they pull on the arm, you pull on the distal radius, and the annular ligament, which is a band of fibers that encircles the head of the radius, it's going to slip up and over the radius and slide into the radial humeral joint where it becomes trapped. So that's what happens here. That's why they have the pain. Somebody pulls here, the annular ligament slides over the head of the radius, the radial head, and then you have this problem that we see here. So the movement of the head of the radius under the annular ligament. As far as the age you're going to see this in, you're going to see this 1 to 4 years of age most common. So it's most common between the ages of 1 to 4 years old. 80% are actually going to fall within the 1 to 3 year age range. So if it's not a young child in the vignette and you think it's a nursemaid's elbow, it's not. This is 100% going to be a young child. The reason we see this frequently in young children, not adults, is because the attachment of the annular ligament is weaker in children than it is in adults. But as the child grows, the attachment between the annular ligament and the radius becomes thicker, it becomes stronger, and it prevents the subluxation. Usually by the age of 5 years old, the ligament is thick and strong enough that it's highly unlikely to tear, become displaced. It's possible you may see this like in an older child, 6, 7, etc., but generally this is going to be under 5 years old that you're looking for this. Mechanism of injury, like I briefly talked about before, it's going to be a pulling injury. So the classic mechanism is going to be parent grabs the arm of the child to prevent them from falling, the child being swung by the forearms, or during play with their siblings or parents. You're looking for some type of pull or tug on the arm in the vignette. The reason it was actually called a nursemaid elbow was because back in the day, they used to have something called nursemaids, which were just like nannies that took care of children, and they were often blamed for causing this injury by tugging on the children's arms. So that's why they called it a nursemaid injury. So remember, pulling or tugging on the arm, that's what you want to look for in the nursemaid elbow. Diagnosis, this is really just a clinical diagnosis. Majority of the time, clinical diagnosis, they had a pulling or tugging type injury, they fit the age range. On physical exam, they don't have any bony tenderness, deformity, or swelling. Usually that's all you need to make the diagnosis. Imaging, usually not necessary unless for some reason they do have one of these things, bony tenderness, etc., where you feel like maybe you need to rule out a fracture. Treatment, so there's very few things in medicine where we can fix someone's problems in a matter of seconds and make them feel completely back to normal. This is one of those few circumstances, and it's very rewarding when you get to do this. So treatment is going to be with closed reduction. There's a couple of different ways to do this. The technique that's preferred by UpToDate, which has a higher rate of success, is a reduction with hyperpronation rather than the supination flexion method, and we can take a look at that here. So the way you do this is you hold the child's arm at the elbow, you place pressure with a finger on the radial head. The other hand holds the distal forearm, and then you hyperpronate the forearm. So you turn the arm all the way over and in. And then a lot of times you may feel a click or feel a pop over the radial head. And that's when it reduces. And these kids, within minutes, will be back to normal playing and smiling. In most cases, at least from my experience. So for radial head subluxation, the main takeaways are you're looking for a child under 5, pulling injury. It's a clinical diagnosis, and the treatment is going to be with a closed reduction. Very straightforward. Now let's talk about medial versus lateral epicondylitis. Let's start with our medial epicondylitis. This is very simple. There's little to know, but you can easily get these mixed up and miss out on an easy question. So let's go over what you need to know, little differences between the two, and then a little mnemonic to remember them. So lateral epicondylitis, this is also known as tennis elbow. This is because it's a frequent complaint of tennis players. Actually, up to 50% of players are going to have tennis elbow, and it's mainly due to poor technique. But this is an overuse injury of the origin of the common extensor tendon, leading to tendinosis and inflammation of the extensor carpi radialis brevis, precipitated by repetitive wrist extension. And the reason why you have pain in the lateral epicondyle is because the lateral epicondyle of the elbow is the bony origin for the wrist extensor. So remember, extension, extension, extensor. This is all about extension. I'll go over that soon because this is what helps differentiate from medial epicondylitis. Now we're going to see this in tennis players. That's what you want to look for in the vignette. Tennis is the most common sport to cause lateral epicondylitis. It can be seen in other sports, of course, where there's similar mechanisms, squash, badminton. If you know what those things are, I'm not really familiar with them. You can also see it in certain occupations like carpenters, bricklayers, seamstresses. But for the sake of the exam, be looking for a tennis player. Now, in physical exam, you're looking for localized tenderness over the lateral epicondyle and pain with resisted wrist extension. So, lateral epicondylitis associated with extension and extensor, pain with wrist extension on physical exam, which we can take a look at here. Overuse of the extensor tendon, the extensor carpi radialis brevis precipitated by repetitive wrist extension. Lateral epicondylitis, remember extension, extension, extension. That's how they're going to get you on an exam question. If you don't remember this and get it mixed up with medial epicondylitis, which is the opposite, involving flexion rather than extension. So again, you can see on the physical exam here, this is going to elicit pain with this resisted wrist extension. So you hold it here so they can't extend up, and you kind of resist that, and that's when they're going to elicit pain. So pain with a resisted wrist extension in lateral epicondylitis. So treatment is going to be conservative, basically NSAIDs, activity modification. If they're playing tennis the wrong way, teach them the right way. Steroid injections, counterforce braces, etc. Nothing really to know. Lateral epicondylitis, again, remember extension. That's what you should associate in your mind. Now let's talk about the opposite, medial epicondylitis, which is known as golfer's elbow. So this is going to be a overuse injury involving the proximal tendons of the pronator teres and flexor carpi radialis, primarily due to repetitive forceful forearm pronation and wrist flexion. So this is the opposite. In lateral, we were talking all about extension and extensor tendons. Now medial, all we're talking about is flexion, the flexor carpi radialis caused by repetitive wrist flexion. Just like we talked about in lateral epicondylitis, the reason why you have pain in the medial epicondyle is because the medial epicondyle is the origin of the forearm flexor and the pronator muscles. So golfers, in the vignette, you're probably going to get a golfer, and medial epicondylitis, as we know, is called golfer's elbow, but around 90% of cases are actually non-sports related. So in particular, occupational settings with repeated forceful gripping during heavy labor like plumbers, carpenters, construction workers. But for the exam, I'd remember golfers. And what they're going to have on physical exam is going to be localized tenderness over the medial epicondyle and pain with resisted wrist flexion. So the opposite, flexion, flexion, flexion. We could take a look here at pain with resisted flexion. You're holding them from flexing in, and they're having pain. So flexion, flexion, flexion. Treatment, same as in lateral. This is conservative, NSAIDs, activity modification, steroid injections, counterforce braces. Nothing to memorize here. So the main thing to remember for both lateral epicondylitis, tennis players, pain with wrist extension against resistance, problem with the extensor tendons caused by repetitive wrist extension. Lateral should equal extension in your mind. Medial epicondylitis, golfers, pain with wrist flexion against resistance, problem with the flexor muscles caused by repetitive wrist flexion. Medial should equal flexion in your mind. If you can remember one, by method of exclusion, you can remember the other, and here's how you're going to do this. So with medial epicondylitis, I want you to remember mini golf is fun. And mini golf is fun because as soon as you think of golfer's elbow, you remember mini golf is fun. Mini, the M helps you remember this is going to be the medial epicondyle, so medial epicondylitis. Golf obviously stands for golfers because we know this is known as golfer's elbow. And the F, the most important thing, mini golf is fun, helps you remember this is all about flexion. So if you can remember mini golf is fun, you can remember medial epicondyle, golfers, flexion with this. Then you can remember lateral epicondylitis is just the opposite, which is going to be wrist extension, lateral epicondyle, and then obviously tennis players instead of golfers. So mini golf is fun, remember that, and you can remember your medial epicondylitis, your golfer's elbow, and then you can remember lateral by method of exclusion. All right, so let's move on to cubital tunnel syndrome, also known as ulnar neuropathy. So this is a compressive neuropathy of the ulnar nerve caused by compression in the medial elbow. We can take a look at what that looks like here. You have compression here, which leads to different paresthesias and things like that, distal to that area here in the hands. So clinical manifestations, this is the highest yield thing you need to know right here. It's going to be paresthesia of the fifth finger and half of the fourth. So we can take a look here. So this is going to be numbness, tingling in the ulnar nerve distribution, which is going to be the most common complaint. So paresthesia of the small finger and then the ulnar half of the ring finger. It's also possible to have pain radiating down from the elbow, but usually what you're looking for is paresthesias in the little finger and half of the ring finger. That's the key here to remember. So what is so problematic with cubital tunnel syndrome is that it can sound very much like carpal tunnel syndrome. And what you can have is a question that says you have paresthesias in maybe the first finger or this finger, and you can't remember, is this cubital tunnel syndrome or is this carpal tunnel syndrome? And you can't remember which is which one, because cubital tunnel syndrome is going to start at the little finger and half of the ring finger. Carpal tunnel syndrome starts at the big finger, the thumb, and it goes all the way through the other half of the ring finger. So how do you remember that for the exam? So cubital starts with the letters CUB. CUB, as we know, are little bears. They're bear cubs. So this helped me remember that this is the one that starts at the little finger, the pinky. And by method of exclusion, you can remember carpal tunnel started at the other end, the big finger, the thumb. So as soon as you see cubital tunnel syndrome, think CUB, a cub. And what is a cub? It's a little bear. And then you remember this starts at the little finger. And then boom, you can remember carpal tunnel starts at the other end, the big finger, and then the other way. That's how I remembered it for the exam. And I got the question right because I just remembered cubs are little cute animals like this guy here. And then I remember cubital tunnel syndrome starts at the little finger, and then carpal tunnel was the opposite. That's all you need to know to remember the difference for the exam question that you'll likely get, and so you don't get confused. Now, physical exam, there's a few different provocation tests for cubital tunnel, but the physical test I remember, the physical exam test I remember is the Tinel sign. So this is the one you're going to hear about the most often. So the Tinel test or Tinel sign, it's percussion or tapping over the ulnar nerve in the ulnar groove of the elbow at the cubital tunnel. And then if they have paresthesia in the fourth and the fifth finger, that's a positive Tinel sign. So there's also a Tinel test or Tinel sign in carpal tunnel as well, so don't get them mixed up, and we'll go over that next. But basically, in cubital tunnel, you're tapping here, carpal tunnel, you're tapping down here. So that's the difference between the two Tinel tests. Now, treatment, conservative versus surgical. Initially, start with activity modification. If this is from some sort of repetitive trauma or occupational cause, you use splints, NSAIDs, things like that. Surgery is really only reserved for severe or progressive symptoms. Let's go over the next one, which can definitely confuse you on an exam, but you're not going to get confused because you can remember cubs are little bears. But carpal tunnel syndrome. So this is compression of the median nerve as it travels through the carpal tunnel. So cubital tunnel syndrome was the ulnar nerve compression. Carpal tunnel is the median nerve compression. Different nerves affected, different nerve distribution in different area affected. This is probably the most important thing to differentiate the two. So in carpal tunnel syndrome, you're going to have pain and paresthesia of the first 3 digits and half of the fourth. So a lot of times the pain will be present at night and wake the patient from sleep. But the hallmark presentation is going to be pain or paresthesia in the distribution that includes the median nerve territory. So the thumb, the first digit, all the way through the first digit, and then the radial or lateral, all the way through the fourth digit, but it's just going to be the radial or lateral half of that fourth digit. So first, second, and third, and then half of the fourth finger. And again, that's different, remember, from cubital tunnel, which started at the opposite end of the hand, the little finger, the fifth, and then included the other half of the fourth digit, the ulnar side. So remember, carpal tunnel, 1, 2, 3, and then half of 4. Cubital tunnel, 5, and then half of 4. Some other things to look out for that are not as important: they may have some weakness, clumsiness when using the hands. They may have difficulty holding objects, turning keys or doorknobs, buttoning clothing. And then sometimes in advanced cases, they may have atrophy of the thenar eminence, which is like right below the thumb there. And then we can take a look at the distribution I just talked about there. So remember the first, second, third, and then half of the fourth finger there. Risk factors. So there's a lot of risk factors for carpal tunnel. Obviously, repetitive hand and wrist use, particularly with some occupations, arthritis, obesity, female gender. But the ones that I would focus on for the exam are pregnancy. Third trimester is usually where the symptoms will start to manifest, although it can be often diagnosed earlier on than this. Diabetes mellitus, so both types 1 and type 2 diabetes were associated with carpal tunnel syndrome. And then hypothyroidism. So hypothyroidism contributes to the development of carpal tunnel by increasing peripheral tissue edema. So those are the ones that usually get tested on. Now let's talk about another high yield area for carpal tunnel that you'll definitely need to know for your OSCEs, and that's your physical exam. So for physical exam, there's a few provocative maneuvers you'll hear about. The two that come up most frequently that you need to know are the Tinel test and the Phelan test. So the Tinel test, just like in cubital tunnel, when we went over tapping on the cubital tunnel, now we're tapping or percussing over the carpal tunnel. So it's easy to get these physical exam tests mixed up. So what I used to remember is that the T in Tinel stood for tapping, as that helps you remember the way the test is performed, because you tap on the median nerve over the carpal tunnel. So positive test is defined when you're tapping as pain or paresthesia over the median innervated finger, so the first finger through half of the fourth. And then you have the Phelan test, which is going to be having the patient bring the dorsal surfaces of the hands against each other, so the top of the hands pushed together to provide hyperflexion of the wrist while the elbows remain flexed. Do this for a minute straight. The positive test is going to be if they have pain or paresthesia in the median innervated fingers. The way that I used to remember this is that this basically looks like the hands have fallen over. They just look like they're flopped down, they've fallen over. And fallen or Phelan test, Phelan kind of looks like you could pronounce it as fallen. So instead of saying Phelan test, I just used to remember fallen test, because the hands look like they've flopped over or fallen over. So again, remember Tinel equals tapping. The T in Tinel stands for tapping, because you tap, tap, tap right here. And then Phelan, hands have fallen over or fallen over, because that's exactly what it looks like. The hands just kind of like flopped or fallen over. That's how I used to remember the tests and what they involve. Treatment, so conservative again versus surgical. I know this is so repetitive. So splinting, glucocorticoids, PO or via injections can be useful for symptom relief in up to 2/3 of patients with mild or moderate carpal tunnel. But in severe or refractory cases, you're actually going to have surgical decompression in these types of patients. All right, so scaphoid navicular fracture. So this is going to be your most common carpal fracture. It's going to be seen in around 60 to 70% of all carpal fractures. So it's an important one to know. It's definitely tested on. Mechanism, another fissure. So falling into an outstretched hand will likely be the cause of a scaphoid fracture, or really any other injury involving anytime you axial load, place an axial load on the wrist. Physical exam, they're obviously going to have pain in the wrist. Where's the pain going to be? It can be in a few different areas, distal to the Lister's tubercle. It can be the volar prominence, but the one that you absolutely have to know, 99%, this is how it's going to be described in the vignette, is going to be at the anatomic snuff box. Know this for the exam. As soon as you see or hear anatomic snuff box tenderness, be thinking scaphoid fracture always. Any tenderness in the snuff box, you need to treat this as a scaphoid fracture until proven otherwise. The snuff box is located just proximal to the base of the thumb. We can see it there. And it's called the snuff box, I think, because they used to put like tobacco in there or something. I don't know, something like that. That's why it was called like the snuff box. But that's where the snuff box is. So if you have a patient that fell, they have any tenderness there, that is a scaphoid fracture until proven otherwise. Now, diagnosis, you're going to get your x-rays. You're going to order a wrist x-ray, including a scaphoid view. The thing about scaphoid fractures, though, is they can often be missed on x-ray. So x-rays taken soon after the injury can be missed up to 54% of the cases. So half of the cases, you're going to miss it. So if the history and exam findings are suspicious for a scaphoid fracture, but the x-rays are negative, you're likely going to have to send these patients for a CT or MRI, because if you miss a scaphoid fracture, the scaphoid unfortunately has a crappy blood supply, and it can be at risk for non-union or osteonecrosis. So if it fits the picture of a scaphoid fracture, but the x-rays are negative, you treat it like a fracture until you can definitively say otherwise. Treatment. Thumb spica, majority of patients with non-displaced fractures who have negative x-rays but have snuff box tenderness, they're going to also need a thumb spica. So you splint until a fracture can be ruled out. With the scaphoid, treat it like a fracture until you know it ain't. And then surgery, if it's a non-displaced fracture, there's neurovascular compromise, surgical repair will be appropriate. Most cases, though, it's going to be with a thumb spica splint. That's what you should generally remember if you're a scaphoid navicular fractures. All right, let's talk about our distal radius fractures, our Colles and our Smith fractures. There's really just a few things to know here. It's mainly being able to remember and differentiate between a Colles and a Smith fracture. So the mechanism is going to be another fouche. So it's the most common mechanism of distal radius fractures. It's falling in an outstretched hand. More often, the wrist is going to be extended in a Colles fracture and generally flexed in a Smith fracture when they're falling. So that's just kind of something to know. Not always the case, though. Now, in physical exam, on a Colles fracture, you may see something known as a dinner fork deformity. They're probably not going to use that because they don't really use buzzwords. But in case you ever hear that, this is what it looks like, and it's basically due to the dorsal displacement of the distal fragment. Colles type fractures are often said to have this dinner fork appearance because you can see how it kind of bends in the fork. Same way with the wrist here. So that's called a dinner fork deformity on Colles fracture. And then a Smith fracture is called a garden spade deformity. Again, don't go crazy memorizing these names because they don't use buzzwords, so you're not going to hear that. But just kind of know in general what these terms mean and what they're associated with. Just have a kind of general understanding. All right, let's talk about what you really need to know. That's on your x-rays or x-ray findings. So you need to know a Colles fracture is going to have dorsal displacement of the distal radius fragment. You need to know that the Colles fracture, dorsal displacement, distal radius fracture. So you can see the distal radius fracture is going up, dorsally dislocated. Remember, dorsal, if you forget what dorsal means, remember the dorsal fin on a dolphin is on its back. Same thing here, like on the back of the hand, it's moving up. So Colles fracture, dorsal displacement of the distal radius fragment. I've said that 3 times. That's really important to know because you need to know the Smith fracture is the opposite, which is going to be volar or palmar displacement of the distal radius fragment. So the opposite, we're going the opposite way. This is the distal radius fracture. Boom, it's going down. Volar or palmar displacement of the distal radius fracture. So you need to remember that. How do you remember that? Because this is really the highest thing you need to know. So it may be the only difference in the vignette. So you need to remember Colles fracture has dorsal angulation of the radius. Smith fracture has volar angulation of the radius. The way that you remember that is that Colles fracture, well, Collie luckily is a type of dog. It's a breed of dog. It's the dog that Lassie was, if you know who Lassie is. I don't know, maybe I'm like aging myself, but Lassie was a collie dog. So you remember when you see Colles fracture, I want you to think of a collie dog, and the first 2 letters in dog are the first 2 letters in dorsal, D-O. So this helps you remember Colles fracture, dorsally angulated radial fractures, and by method of exclusion we know a Smith is the opposite, volar angulated radial fracture. So when you see Colles fracture, think of a collie dog, D-O, dorsal angulation, then you'll remember. You can differentiate the 2 on the exam. So that's the main thing to know for your distal radius fractures that can be treated. So as far as treatment, it's going to be splint reduction versus surgery. Some fractures can be treated with a closed reduction and a sugar tongue splint. Other fractures, depending on severity, may require surgical repair. So let's talk about our lunate fractures next. Lunate fractures are really uncommon. They're only about 4% of all carpal bone injuries, but they do have some pretty serious complications if they're not treated. So let's talk about that. Mechanisms pretty straightforward. Fall into an extended wrist. Other types of wrist hyperextension injuries can also cause these. Those are going to be your most common mechanisms of injury for the lunate fractures. As far as diagnosis, you're going to get an x-ray. Main thing to know about x-rays for the lunate is that they're often missed with plain radiographs. So if there's clinical suspicion, it's always important to obtain advanced imaging like CT or MRI. CT is going to be preferred in this case. One thing that I wanted to mention, because it may come up, when you have a dislocation of the lunate bone, the lunate gets displaced, it's angled in this volar direction, and in comparison to the surrounding structures, the distal radius, metacarpals, which are all in otherwise normal alignment, it looks like a teacup spilling over on lateral x-rays. This is what it looks like here, and it's called the spilled teacup sign. So just in case you ever see anything like this on an x-ray, you'll know this is the spilled teacup sign, and it's related to lunate dislocations. Complications: avascular necrosis, Kienbach disease. So this is a progressive collapse of the lunate. The mechanism is really unclear, but it appears to involve disruption of the blood supply, which is likely related to undiagnosed fractures of the lunate. That's why you want to get your advanced imaging. If there's any suspicion, you don't see it on x-ray. Some other complications seen with lunate fractures are complex regional pain syndrome, osteoarthritis. Nothing specific I know for treatment, except in the case of a dislocation, in which immediate reduction is really important to prevent further complications. Let's talk about dequerre vein tendinopathy next. So this is a thickening of the abductor pollicis longus, APL, and extensor pollicis brevis tendons, and the tunnel or the sheath in the first extensor compartment. So the abductor pollicis longus, the APL, and the extensor pollicis brevis tendons pass through this tunnel called the fibroosseous tunnel from the forearm into the hand. And any thickening of these tendons passing through here, or the thickening of the tunnel itself, can restrain the gliding motion through the sheath, and it can lead to the clinical manifestations we'll go over. So just think of like a rope going through this little hole, and either the rope's getting bigger or the hole's getting smaller, and eventually it's getting stuck. So I don't recommend memorizing abductor pollicis longus and extensor pollicis brevis. It's just too much brain power to remember those complicated names. But what I would recommend is memorizing apples with extra peanut butter are delicious, because if you can remember that, you can remember what you need to know. So if you can remember apples, APL as in APL tendon, with extra peanut butter, EPB, extra peanut butter as in EPB tendon, are delicious as in dequerre vein tendinopathy. That's going to help you remember the APL tendon and the EPB tendon from apples with extra peanut butter are delicious, and it should be enough to help you pick them out on a multiple choice question by remembering the letters involved in the full name. Listen, if you can memorize abductor pollicis longus and extensor pollicis brevis in addition to the 20,000 other things you need to know for PA school, more power to you, go ahead. I just remembered apples with extra peanut butter are delicious, and that was enough for me to pick it right on the clinical medicine exam. So apples, extra peanut butter, delicious, APL, EPB, that's what you need to know. What's the patient demographic you're going to be looking for in decorative vein tendinopathy? That's going to be women 30 to 50 years old. And it's also most common, or it can be seen in postpartum period. So symptoms usually preventing about 4 to 6 weeks after delivery. A lot of theories why this happens. They say it may be from repetitive motions of the hands required to lift and hold newborns, hormonal causes, fluid retention. Whatever the case, you're looking for both women in the 30 to 50 year age range and also postpartum women. That's what you want to look out for. Clinical manifestations, you're going to have pain at the radial side of the wrist, worse with thumb and wrist movement. The tendons we went over before, the EPB and the APL, they're responsible for movement of the thumb. So you can imagine a lot of the complaints will be related to thumb movement. Now, diagnosis. Decorative vein tendinopathy the diagnosis is based on the history of atraumatic radial wrist pain and positive physical exam findings. So imaging like x-ray is not really necessary except to rule out other differentials, which may have a similar presentation like osteoarthritis. The main thing, though, to know for diagnosis is a physical exam maneuver called the Finkelstein test. So the Finkelstein test is a provocation test. Let's take a look at it here. That involves the patient wrapping their fingers around their thumb, clasping it in the palm, and then applying ulnar. Then you push and apply ulnar deviation to the wrist. If they have pain over the radial styloid area, so the base of the thumb, this is considered a positive test. So Finkelstein test, remember that. Treatment is going to be it's generally a non-progressive and self-limited condition. So conservative measures are going to be your mainstay. So sometimes we can use a thumb spica splint. Sometimes you can use NSAIDs. Glucocorticoid injections are another option. Surgery is really only for refractory cases. Okay, mallet finger. So this is a finger deformity caused by traumatic disruption of the terminal slip of the extensor tendon at the distal interphalangeal joint. So you have some sort of trauma to the finger, usually caused by a direct blow to the tip of the finger. So like a ball striking the fingertip, or the fingertip strikes a hard surface. The trauma causes a tear in the extensor tendon at the DIP joint, and this is the tendon that allows you to extend your fingers and hold them straight out. And with this being torn, you can no longer do that. So the finger remains in this constant state of flexion. Now, in physical exam, you're going to see an inability to extend the DIP joint, and that's going to result in this flexed DIP. We can see what that looks like here. So it's really simple. The patient will have this constant flexion at the DIP joint. It's a pretty exaggerated case, but you're going to see something similar to this. They're not going to be able to extend the finger at that joint. The specific degree of DIP angulation often reflects the severity of the tendon disruption. Diagnosis, you're going to do your x-ray. So in some cases with a mallet finger, you can visualize a bony avulsion at the distal phalanx, which we can see here. And that's pretty common. You see this a lot of times with x-rays. When you have a patient with mallet finger, so where the tendon attaches, it just gets ripped off during the injury. It's also possible to just have a ligamentous injury with normal bony anatomy. So you don't have to see this, but this is very often seen on x-ray with mallet finger. Treatment is going to be extension splinting of the DIP joint for 6 to 8 weeks, 24 hours a day. So the DIP joint must be maintained in full extension throughout the entire period, including during sleep. If for any reason the joint extension is lost at any point during the initial treatment period, the treatment clock is reset and an additional 6 weeks of splinting must be performed. So if you think about it, this is what's going on here. So if you have the finger extended, you basically have either the avulsed injury lining up here, or you have the extensor tendon lining up here when the finger is extended. So this is kind of meeting up here. Now, for any reason you lose that extension and the finger bends, it's just going to pop, and you're going to go right back to where you were at day one. So if at any point it loses that extension, they bend it, you have to start all over again. So it's basically 6 to 8 weeks it needs to be aligned. The majority of mallet fingers are amenable to treatment with just splinting. Surgery is really only going to be reserved for large displaced fractures, other complex injuries that are going to warrant surgical referral, but really focus on splinting as that's going to be the most common treatment. So mallet finger again, extensor tendon injury, DIP joint now flexed all the time, can't extend it, straighten it out with a splint, done, that's mallet finger. Now let's talk about our ulnar collateral ligament injury, also known as gamekeeper or skier's thumb. So this is an injury caused by damage to the ulnar collateral ligament of the thumb. Mechanism, we can take a look at that here. Mechanism of injury is going to be a forced abduction and hyperextension of the thumb. So this is going to be at the metacarpal phalangeal joint. This is going to be the most common cause. So the thumb is basically stretched and forced into extreme abduction, whether this is from a fall, an athletic injury, skiing accidents, which is where the name came from, where the thumb strikes a fixed ski pole and it just bends back. And then there's also the name gamekeeper's thumb, so it's definitely not relevant anymore. But basically what this was, it was this chronic degeneration of the ulnar collateral ligament from twisting the necks of too many birds and rabbits. And that was a gamekeeper, and that's what they did. So probably won't be the reason why your patient comes in with this, but 70 plus years ago when the name was created, it was. But likely today it's going to be more related to a skiing related injury or some athletic related injury. Physical exam, you can pretty much confirm an UCL injury with your physical examination combined with appropriate clinical manifestations. So what you're going to do is you're going to do valgus stress testing, which is going to reveal a loss of integrity of the UCL. So the injured thumb will have increased laxity of the MCP joint of the thumb, so it's going to pull much further away compared to the uninjured thumb when valgus stress is applied. So if you see in this picture, this is a complete tear. So this is pretty significant. It may not bend back that far, but this is a complete tear in this case of the UCL. So if this test is positive, the patient has the classic clinical manifestations: pain exacerbated by thumb extension or abduction, swelling along the ulnar aspect of the thumb at the MCP joint. This helps to confirm the diagnosis. But you also want to get an x-ray of the thumb to rule out any possible bony avulsion fractures. You can make a definitive diagnosis with MRI or ultrasound, but generally it's not necessary. Treatment's going to be with a thumb spica splint, so mobilization with a thumb spike will be sufficient in most patients. Some patients with a complete tear or patients who don't respond to conservative therapy may require surgical intervention. Boxer's fracture. This one's pretty straightforward. Fracture of the fifth metacarpal neck. Generally, we're talking about the fifth metacarpal neck when we're talking about Boxer's fractures. Occasionally, some sources may also refer to it as fractures as the fourth metacarpal as well, but generally it's going to be the fifth metacarpal neck. Mechanism of injury: direct trauma to a clenched fist. So obviously the most common situation, you're going to have direct trauma to a clenched fist. It's going to be punching something, a wall, a solid object, a face. So it's called Boxer's fracture. In reality, though, experienced boxers actually rarely sustain this type of fracture. It's more the wild roundhouse punching motion that's common in street fights, where someone who punched a brick wall is going to come in with this type of fracture rather than, say, Floyd Mayweather. Diagnosis is going to be with x-ray, so plain radiographs of the hand. That's going to establish the diagnosis of the metacarpal neck fracture. We can take a look at what that looks like here. It's also going to help to determine the degree of fracture angulation. Treatment: mobilization with an ulnar gutter splint that's going to be used to immobilize the fracture of both the fourth and the fifth metacarpal necks if they're both fractured. If the patient has an open fracture, severely comminuted fracture, or a fracture with significant angulation, usually over 30 to 40 degrees, it's going to require surgical consult. Otherwise, mobilize with the splint. And let's finish up with something a little bit different. We're almost done here. Complex regional pain syndrome. So this is an array of painful conditions that are characterized by a continual regional pain that is seemingly disproportionate in time or degree to the usual course of any known trauma or other lesion. That's the official definition. Let me put it into my terms. So basically, these patients have this prolonged pain. It's disproportionate to whatever initiating event there was. So most frequently this is going to follow a bone or soft tissue injury. They're going to have a sprain or a fracture. Most cases there will be some sort of injury. In some cases it is possible to have no precipitating factor. It's not common. And then weeks later they start to develop this range of these odd clinical manifestations: autonomic dysfunction, pain out of proportion to the initial injury, hair and nail changes. The patho is really unknown, some proposed mechanisms, but nothing really to know for the exam. Now, clinical manifestations, this is the most important thing about complex regional pain syndrome. It's the presentation. Diagnostic criteria is low yield, the treatment's low yield. It's all about being able to recognize the clinical manifestations. That's what you need to know for this. So the main clinical manifestations of complex regional pain are pain, obviously, sensory changes, motor impairment, autonomic symptoms, and trophic changes in the affected limb. This is usually going to occur 4 to 6 weeks after the inciting event, and the reason I'm covering this under the upper extremity section for the PANCE is because it most commonly occurs in the upper extremities. Can happen in the lower, but around 60% of the time it's going to be in the upper extremities. So the way that I remembered the common clinical manifestations that you'll see in a vignette for complex regional pain is, instead of remembering complex regional pain syndrome, I remembered complex regional pain syndrome. And what does PAINT stand for? Perspiration. So the P stands for perspiration. This is due to the autonomic dysfunction. 40% of patients will experience increased sweating, and pain in your stands for after injury. So this is most commonly going to take place after some sort of bone or soft tissue injury. So look for some sort of injury mentioned in the vignette weeks prior. I stands for inappropriate pain, because remember, the pain is inappropriate. It's out of proportion to the initial injury. Pain is typically the most prominent and debilitating symptom of complex regional pain. So remember, I stands for inappropriate pain, because it's not appropriate to have 10 out of 10 pain in your wrist from a sprain you had 2 months ago. So I, inappropriate pain. And then N stands for nail changes, because remember, your trophic changes, these patients can have both increased or decreased nail growth. Also look for changes in the hair as well. And then the T stands for temperature changes. Relating back to the autonomic changes, these patients can have, some patients you'll see a difference in skin temperature on the affected versus the unaffected side of over 1 degree Celsius. So remember, if you have a vignette, you think the patient, they're talking about complex regional pain syndrome, remember to look for pain, perspiration, after injury, inappropriate pain, nail changes, temperature changes. That should be enough to get you the right answer. And then diagnosis is going to be pretty straightforward. It's clinical features, basically. Clinical diagnosis is clinical features based on your history and physical. Nothing to know here for the exam question. You're basically looking to see, do they have pain, sensory changes, motor symptoms, autonomic dysfunction? Are these symptoms weeks out for an initial injury that no longer be appropriate at this time? There are some imaging tests that can be used, 3-phase bone scintigraphy, radiographs, but there's nothing high yield. There's no gold standard test, and definitely nothing I'd memorize for the exam. This is generally a clinical diagnosis. If they're experiencing pain, then it's complex regional pain syndrome. Treatment, it's multifaceted. You have physical therapy, NSAIDs, tricyclic antidepressants, sympathetic nerve blocks, physical and occupational therapy. Physical and occupational therapy are more or less going to be your first line treatments for complex regional pain, but again, it's multifaceted, multidisciplinary approach. There's not one specific thing to know for the treatment. Main takeaway for complex regional pain is identify it in a vignette. The rest of the stuff is not very high yield. Remember your pain. All right, let's test your knowledge. Let's do 5 quick questions. First question. 32-year-old female presents to the office complaining of pain at the radial side of her wrist that is most prominent upon movement of the thumb. She is 4 weeks postpartum. Past medical history is otherwise unremarkable. On exam, tenderness is noted over the radial styloid, and pain is experienced with passive ulnar deviation of the wrist with the thumb flexed in the palm. What is the likely diagnosis in this patient? So that is going to be decorative vein tendinopathy. So decorative vein tendinopathy we know is most commonly seen in women between the 30 to 50 year age range. Also common to see in postpartum women 4 to 6 weeks after delivery. So she fits this criteria to the T. Then we see she has pain in the radial side of the wrist. On physical exam, tenderness over the radial styloid. Positive Finkelstein test where the patient's wrist is put into ulnar deviation while the patient's fingers are folded over the thumb. Classic presentation for decorative vein tendinopathy. Question 2. 43-year-old female presents to the office complaining of numbness and tingling in her hands, mostly affecting the thumb, index, middle finger, and part of the ring finger. She states it is worse at night and sometimes waking her from sleep. Both the Tinel and Phelan test are positive on physical exam. This patient is likely experiencing compression of which nerve? So that is going to be your median nerve. This patient is experiencing carpal tunnel syndrome, which is compression of the median nerve. We know this because we have a patient with paresthesias in the median nerve territory, which would be the first 3 fingers, and radial half of the 4th. In addition, she states it's worse at night, which is very common for carpal tunnel. And then finally, we have a positive Tinel and Phelan test, which seals the deal. We know this is carpal tunnel, which is median nerve compression. Question 3, a 27-year-old male presents to the ER after a bicycle accident he had earlier on in the day. He states his bike hit a pothole, which sent him flying off his bike, landing on his outstretched hands. He's now complaining of pain along the radial side of the wrist, which is tender just proximal to the base of the thumb at the anatomic snuff box. Fracture of which bone should be suspected in this patient until proven otherwise. So we know that is 100% the scaphoid. So it's a simple one, scaphoid or navicular fracture. You have a patient who had fallen into an outstretched hand, which we know is the common mechanism of injury for a scaphoid fracture. He has pain on the radial side of the wrist, snuff box tenderness. You are done. That is a scaphoid fracture until proven otherwise. As soon as you hear snuff box, always be thinking of scaphoid fractures. Question 4. 67-year-old male presents to the office today complaining of persistent elbow pain. He does not recall any trauma to the elbow, but the pain he is experiencing in his elbow is affecting his golf game as he is an avid golfer. On exam, pain is elicited by performing wrist flexion against resistance. Tenderness would likely be felt in which part of the elbow in this patient? So that would be at the medial epicondyle. So we have a classic case of medial epicondylitis, aka golfer's elbow. We have a 67-year-old male, avid golfer with elbow pain, no preceding trauma. The key is the pain that's reproduced on exam with the wrist being flexed against resistance. The way that you remember this is mini golf is fun. The M in mini helps you remember this is the medial epicondyle involved in golfer's elbow. Golf, obviously, because this is golfer's elbow. And the F in fun helps you remember this involves flexion because it's pain with wrist flexion against resistance, or the fact that it involves the flexor carpal radialis, or that it's caused from repetitive flexion. So mini golf is fun, M in mini, medial epicondyle, golf for golfer's elbow, and F for fun, flexion, flexor. And then, lateral epicondylitis is the opposite, problems with extension, not flexion. All right, question 5, last one. 17-year-old male presents to the ER after sustaining an injury to his right arm. After x-rays are complete, the attending physician assistant informs him the x-ray revealed a proximal ulnar fracture accompanied by a radial head dislocation. This type of injury is also known as, and that is going to be a Monteggia fracture. So remember, gruesome murder for Montegia and Galiazi fracture. So gruesome, first 3 letters in gruesome, GRU. G stands for Galeazzi. The R stands for radius fracture, the U for ulnar dislocation, aka radial ulnar joint. And then murder, which stands for the first 3 letters, MUR, M standing for Monteggia, U stands for ulnar fracture, and R stands for radial head dislocation, which is the type of injury we see here in this patient. All right, that is it. Thank you so much for watching the video, and thank you so much for the support. Good luck on your PANCE, your PANRE, URs, and good luck in PA school.